Not many people call me Michael J. Many of you who know me there will know I go by Mike. And sorry for not being with you there today at the conference. I'm currently in Congo. We had some problems with the video connection because of a massive thunderstorm here, which I think is actually preventing our Trócaire colleagues landing in Beni. But Beni is in North Kivu, is the current epicenter of the outbreak. Situation here, frankly, is challenging, and it's testing every aspect of our collective response capacities. Yesterday, we reached the unfortunate number of 300 cases of Ebola, and we are operating in the context of an ongoing humanitarian crisis and extreme conflict. At the moment, we're tracking 5,500 contacts every day. We have 91 inpatients in 3 Ebola treatment units, 2 provided by our colleagues in MSF, thanks Sam, and 1 by Alima here in Beni. MSF are also in the process of building a very important and necessary transit centre in Beni, so we can decompress the pressure on the current Alima centre in Beni. We have 133 patients treated with novel antivirals and antibodies under a MURI investigational use protocol. We've vaccinated over 24,000 people in the response thus far with an investigational vaccine, EBOV, and continue to try to get the job done. Unfortunately, the security situation is difficult and extremely fragile, with a large-scale armed conflict with a number of anti-government elements against the forces of the national government. And in the midst of this, we have a UN peacekeeping operation of the 4th Intervention Brigade of SADC and MONUSCO, the mission for peacekeeping here from the United Nations. Frankly, our communities are completely traumatized by the ongoing violence over years, by the massacres, the kidnappings, the executions, and very often react to that lack of security after incidents with street protests and real more or complete shutdown of civic work, which has happened now on at least 4 or 5 occasions over the last 2 months, and completely disrupts our operations for days on end. We have many brave Congolese and international workers in the communities every day, but it can be very difficult to maintain operations in the environment we face. Additional community engagement in the face of Ebola has been extremely difficult. There's a deep lack of trust in government, and particularly in the government health system, and more faith in the traditional and private health networks. The system most preferred by communities here is the tradi-modern approach, which is essentially a mix of traditional and mainstream medical practices. In Beni alone, we have over 250 healthcare structures and facilities that are not government-based and that are essentially run by this tradi-modern private network. The problem with this is that this system has become deeply implicated in both disease transmission and in significant delays in detecting and isolating suspected cases of Ebola virus disease. The situation really demonstrates true complexity of epidemic containment in this unstable security environment, and delivering effective risk communication, surveillance, laboratory services, vaccination, case management operations in this context is difficult, but we are getting the job done. We have successfully contained the disease in Mangina, Mabalako, in Makeke, in Wicha and Kamanda, which are red zones in terms of security, and in Chomia. We maintain preparedness operations and rapid response teams in Bunia and in Goma. And currently the epicenter of the outbreak is here in Beni, with significant transmission of disease in Butembo, which is to the south of Beni, and in the areas in between here and Butembo to the south, which is in the main Mai controlled area. The Allied Democrat, the ADF rebels operate to the northwest of Beni and engage in systematic attacks on the town and FARDC. The Mai operate to the east and south. and control much of the territory in which we now have significant transmission. A good example is the village of Kanyahunya in Kalanguta, just to the south here of Beni. We've had a large number of deaths in a single village, with further transmission in that village. This is a Mai controlled village, then extremely difficult to access, and a very, very sensitive process of engagement with that community in order to assure access. We do have access now, and they're tracking contacts and vaccinating people as we speak. We're relying heavily on partners from the NGO and international community, the Global Outbreak Alert and Response Network, including UNICEF, MSF and the Red Cross, to support a government-led response, and to recognise, and this is the government are leading the response and have provided some excellent leadership in doing this. The Director General for Health, Dr. Bate, has been here in the field with us since the very beginning and spent 3 months leading from the front. We have many other NGOs, IFGH, Save the Children, Oxfam, Caritas, Mercy Corps, MEDAIR, and others working with us, mainly in community engagement, in infection prevention and control, in health structure, and in feeding programs, supporting Oxfam and others, supporting feeding programs for victims and contacts under the leadership of the World Food Programme. I suppose this is the front line of global health security. And a number of risks have converged to try to amplify a dangerous outbreak in a vulnerable population, and which now threatens the rest of Congo and the region and beyond. This is a zone of high, significant biodiversity. It's a zone of high population density, exploitation of the forest for economic purposes, a huge amount of conflict, huge population mobility for security and economic reasons, an ongoing humanitarian crisis, disrupted development, and a profound weakness of the health system. So I suppose for your conference today, the question in an extreme situation like this is, can we really talk about the title of the session, Effective Partnership and Strategies that Bridge the Humanitarian Development Nexus? Well, I think we can, and frankly, I think we must. This epidemic is not driven by a virus. It's driven by human behaviour, human systems, the disrupted development cycle, the lack of essential services such as health. We all, and those of you at the conference, have drank the Kool-Aid, but the world and many others need to wake up and realise that the best form of epidemic prevention and mitigation is a health system that can deliver essential health education and services to its population, linked to an effective public health service capable of detecting and responding to epidemics quickly. Our analysis in the Emergencies programme is that over 60% of preventable mortality targeted in the SDGs is located in 30 fragile, conflict-affected and vulnerable countries. And 80% of significant epidemics are occurring in these same countries. We don't get to the SDGs or to global health security without a significant investment in health systems in these countries. I think this necessitates a deep partnership between the humanitarian and development communities. These aren't separate issues, but intimately linked, especially when it comes to epidemic preparedness and response. Health systems and health emergencies, as Dr. Tedros said many times, are two sides of the same coin. So many thanks again for the opportunity to speak with you all. I hope I've come across clearly. I actually hope to be home in Ireland very soon for a few days R&R with my family in Galway, and I'll hopefully be raising a pint in Noctons sooner than I think. So thank you all, and I'd be very happy to take any questions. Over.
Thank you, Mike. So we're opening the floor for any questions that you might have there. Yep, go ahead.
Thank you very much. Thank you, Michael. I just wondered, in terms of the experience in the Ebola crisis in West Africa and the strengthening there of community surveillance networks and how that really helped to contain the epidemic, is there any chance of applying the same approach there, given that it's a conflict situation?
That's actually an excellent question. Absolutely, and in fact, I would argue that the more conflict and the more disrupted the systems is, the more you have to rely on community resilience, community engagement, and community-based surveillance. Communities here are really beginning to understand what Ebola is, and they have the solutions. We're just here to provide them with the support to prevent disease transmission. So you're absolutely correct. Community-based surveillance in these situations, and not just surveillance, it's an engagement and a partnership with that community. It's exactly the same when it comes to the healthcare facilities. There's a demand for service from those facilities, and the communities can change the behaviour of those facilities way better than we can by their demands and their engagement with the facilities that serve them. So a community-based approach, in my experience, is the only way you get rid of Ebola. Yes, the vaccines help, the surveillance helps, the drugs help, but without an engaged and participating community who own the problem and own the solution, we will always struggle in situations like this. Over.
Thank you, Mike.
Hi, Mike. Margaret Fitzgerald here. Good to see you again, even though we don't really see you. Good to hear the voice. I'm just wondering about WHO, whether you intend to go to a higher stage of action and international liaison. As you know, we receive a high number of people from DRC looking for asylum, and there are no particular measures at the moment to prepare for these. Thank you.
I think that question might be for someone else, Margaret, but good to hear your voice as well, Margaret. We might have a drink in Lewisburg soon.
No, but that, Margaret, that was directed at Mike, that question, no?
Sorry, Mike, just to elaborate whether WHO intend to issue any further, what's the trigger point to have a heightened international...
okay.
Yeah.
Okay. No, I thought you were talking about refugee and asylum issues, Margaret. Sorry, yes. No, the Emergency Committee of the IHR has met once and has considered the epidemic. I think it stopped maybe 1 inch short of declaring a public health emergency of international concern. Clearly, the surrounding countries have high levels of preparedness. I think we've screened now over 15 million people at the borders around Congo, particularly the borders to Congo, Sudan and Rwanda. So there's a very intense process. Governments of the surrounding countries have approved the use of investigational vaccine and healthcare workers. And as I speak, I hope that's beginning to roll out, especially in Uganda for frontline health workers near the border, so we don't end up with the kind of nosocomial transmission we would have had here. In terms of travel advisories, we don't advise a restriction of travel into Congo. I mean, this outbreak is limited to a very, very tiny footprint within the country. There is significant population movement, but the direct risk is to those countries that directly abut the northeastern part of Congo. I don't believe there's any particular risks in Europe or elsewhere, other than the normal vigilance that will be necessary at airports and with physicians and others. Someone returning from Congo with a fever is much more likely to have malaria. So therefore, being alert is always good, but I don't believe at this point we need specific restrictions or specific measures in relation to international travel to or from the Congo. Over.
Thank you, Mike. Are there any more questions from the floor? Yep.
Hi, Mike. My name is Hattie from Goal. It's very exciting to hear someone from the front line, as opposed to us all sitting here in the room looking terribly smart. I was just wondering, so what countries like Uganda have relatively frequent outbreaks of Ebola, but they're very, very quickly quashed and contained. So I was just wondering what is done differently in those countries that are exposed to it frequently and are able to deal with the situation quickly. What's the difference between the two contexts, or contexts that aren't able to deal with it, and subsequently we end up with an emergency response and a considerable outbreak?
Thanks, Eddie. A very good question. Like all systems, I think human nature is we only learn through crisis and disaster. And much of the reason why Uganda has a pretty efficient mechanism for responding to epidemics like Ebola is related to, about outbreaks like the terrible outbreak of Ebola in Gulu in 2000, which I was involved with myself as field coordinator. And those kind of shocks to the system, I think, wake everybody up to the reality. And in that time, since Congo has implemented, systematic field epidemiology training, it's done a lot of work on it's a viral research institute and its capacity to rapidly diagnose disease. It has established rapid response teams at Ministry of Health level who can immediately go to the field and have the necessary resources. It's still a challenge in the context of any developing country, but you can see that the basics are there. The other thing in the likes of Uganda is, with the experience with HIV and other diseases, the community engagement and community-based approaches to healthcare delivery are much more developed. There is more faith in the government system, so therefore outbreaks do tend to get detected more quickly, and communities tend to engage and respond and comply with public health measures more readily. That's a huge generalization, but I certainly wouldn't like to see this disease, for example, getting into somewhere like South Sudan. I know Sinead Walsh is our new ambassador in South Sudan. I've had messages from her expressing her concerns on preparedness there. So it really comes down to the previous experience of the country. It comes down to people often ask me, what's the best form of epidemic preparedness and response? And I very often say three things: 1, governance; 2, governance; and 3, governance. I think it really comes down to what does the government see this as an important issue? Does the government put in place the necessary investments to build the basic health and public health system? But yes, you're right. Uganda has a pretty impressive record of response. But we have been working with Rwanda, Burundi, Congo, Uganda and South Sudan very intensively, and I've had teams in those countries for the last number of months now, working with them on preparedness measures. So I hope we don't ever reach the horror that was West Africa. We've had time, we've had lead time, the countries have had time to prepare, and I hope to God that if, God forbid, the disease does reach any of those countries, we will be able to snuff it out quickly.
Thanks. So very quickly, the advert won't last more than about 35 seconds. UK Meds, small NGO. We're based in the UK in Manchester University. We're focused on trauma and surgery and outbreak response. And we identify, recruit and train medics largely out of the NHS for deployment overseas, either with the UK emergency medical team or with other NGOs or through the UN system. So we did have someone out with Mike's team in DRC earlier this year. Right, now. How do I move this on? Sorry. Okay, cool, got it, right. Sorry, I'm technically challenged. Used to be a really simple world. Certainly when I entered this sphere in about 20 odd years ago, we just thought in terms of a continuum. That was what relief to development was supposed to be, a nice continuum. And it followed this kind of model of there'd be some sort of shock, there'd be a period of emergency response, there'd be a period of recovery, and then everyone would slip back into development again and it would all be fine. That was the thinking. Of course, the reality was a little bit different to that. And what we found repeatedly, and this is probably a familiar picture to most of the people in the room who have worked in a DRC or a South Sudan or a Somalia or any such place, you start off with a shock, perhaps. The period of emergency response is greatly elongated because there are a huge number of emergencies to deal with. And then you get into a system where essentially you are delivering basic services in substitution for government. And that would describe the situation in a great many fragile states. where essentially there's a large body of UN and NGOs who are all essentially substituting for government and dealing with spikes and crises along the way. So every so often there would be some kind of crisis or emergency shock, such as Ebola in DRC. But it's one shock within a far greater context of fragility and conflict. And we never actually really reach a position where the entire country is engaged in development, although development and development activities are indeed possible within a fragile situation. So it's much more complicated. And that, I suspect, is what led to the use of the word nexus, which is slightly frustrating, I imagine, because it does seem to overcomplicate things conceptually, but essentially we're dealing with a situation in which, for a large number of states, we have to respond to emergencies, we have to deliver long-term services in substitution for government, and we have to look at system strengthening and development activities all at the same time. That's basically what it comes to. Some arguments against this, and these are the sort of, the basic quibbles around this kind of nexus and coherence has been, if we're combining development and humanitarian action at the same time, will we subsume humanitarian action? Will we erode humanitarian principles? Will humanitarian action become part of a wider political agenda in state building? Very valid question, hasn't been answered, but the question has been out there for a good 15, 20 years now. How do we ensure that responses plan for the long term right from the start of an emergency response? People are engaged in dealing with an emergency response. How can they plan for the long term? How do we coordinate effectively between all of the different multiplicity of actors and agendas? And how do we identify ways to build to the longer term? So all of those issues come up. And going down through all of these, the sort of tendency for people to feel very overwhelmed by the multiplicity of agendas and different instruments and different formats and different proposal types. I think for any of us that have worked in any of the sort of fragile states, you find that just wading through the sheer bulk of donor requirements and different agencies' agendas, it just becomes overwhelming. And in the end, people just sort of shelve it and carry on with whatever they were doing. Even within the same organisation, it is often difficult for people on two sides of the relief, on either side of the relief and development coin, to have a coherent conversation. Often people will approach quite sort of rational conversations from a point of view of conflict. Ultimately, it comes down to sort of personality types and whether one is a believer in principle trumps all or the process is all important. If you're on either side of an extreme development and relief argument, you will have an ethical framework in which you are either obsessed about the principle or you are obsessed about the process, and if you don't have a perfect process, you will not have a perfect outcome. And those two personality types are at the sort of root of this conflict, even within organizations. You see it time and again. Obviously, I'm overstating it, but I'm sure we're all familiar with those kinds of arguments. Within this, we now have EMTs. For those of you that are unfamiliar with EMTs, emergency medical teams. A few years ago, they used to be foreign medical teams, but they've been renamed emergency medical teams. This is something that grew out of the Haiti response. So for those that may be familiar with Haiti, I won't go into all of the statistics, but far too many inappropriate surgical interventions, far too many inappropriate medical actors without standards. So it's particularly looking at medical responses. And there is now an entire EMT system housed within an EMT secretariat in WHO, so within Mike's team. We have Ian Norton and team who run an EMT secretariat, and they set standards in something called the Blue Book, which set out exactly how we should all operate and how we should act. And EMTs are there to provide surgical care through field hospitals, outbreak response, and indeed a whole load of other medical-related services. EMTs are not perhaps long-term thinkers. I think it has to be admitted. And they are frequently characterized by very time-limited deployments. So, for example, OSMAT, which is the Australian EMT, only deploy for 2 weeks at a time. That's it. They're in and out. This is the kind of thing that they are focused on. That's what they're interested in. That's what they're thinking about. And it's very, very short-term, fast, go in, get things done, do it properly. That's the thinking, the culture. So people are concentrating on exit strategies rather than any kind of long-term engagement with systems and coordination and how do we build back better and how do we ensure that this perhaps doesn't happen again in the future. And they're often government entities. Some are not, but many are. So of the emergency medical teams that are verified, have the WHO kite mark, I think there are about 13 or something at the moment, so not terribly many. Most of them are government entities, and they're derived from either military, civil protection, fire service, and a combination of whatever government medical service happens to be in place in that country. And they're brought together, and they're deployed out for a very short period of time. They do their job, they come back for tea and medals, and that's it. Literally. Everyone got a medal from Ebola. Which is very nice. It's got a nice... Sorry? So sometimes there's this real challenge of culture about how they engage with the wider context. How do they coordinate with NGOs who have a very different culture and philosophical background? And how do they engage with governments? They're quite happy to engage with governments. They're quite happy to be coordinated by the UN system. But they're very unaware about the kind of debates that we have in this sort of forum. There certainly needs to be a far greater engagement and coordination on the part of EMTs. I don't think there's any question. EMTs understand that. They're just not clear how to do it. They don't really see themselves as part of the humanitarian system. They are and they're not. There needs to be some kind of erosion of the barriers between them and the rest of the NGOs. They're never going to really be NGOs, but they can be a useful supplement, and they can be directed to engage with the arguments and the debates in a coherent way. They can be, and they're probably willing to engage with that. And they should be looking at how they engage relationships within the context that they're likely to have to deploy to. And some of them do. Some of them do. So particularly with capacity building and preparedness. So many EMTs, us, for example, we don't deploy that often. We deploy at the behest of DFID when we are deploying as the UK EMT. When we deploy as UK mode, we can do what we want. But when we're deploying as the UK EMT, it's comparatively rare, once a year. Once a year. This year it was Bangladesh for diphtheria. There might be another one towards the end of the year, we'll see. DRC may get worse. But in between times, there's a lot of engagement with capacity building and preparedness for us. And this is something I think many of the other EMTs need to engage with, to make sure that we have some kind of relationship with the governments and the countries and the NGOs that we might deploy alongside or within. And to make sure that the people that we are deploying, and let's not forget that many of the people that we deploy are doctors and nurses and other medics from the National Health Service. Many of them have not travelled extensively, most of them have not worked in NGOs before, and there's a lot of training and preparation in order to get those people attuned to the kind of context and the people they will be dealing with and have to negotiate with. And the more that happens, obviously, the better and the more attuned EMTs will get. But I think there is no doubt that EMTs are here to stay. I think that is probably not in question. They're a very useful policy tool for governments, and governments quite like them. They are a driver of standards. I think there's no real question about that. Whether those standards can be sustained or paid for across the entire sector is a whole different question. But they are a driver of standards, and I think that has to be seen as in a positive light, and people have to we have to take that and work with it. and they can be a very useful supplement if engaged with them in the right way. Perhaps not all of the more full governmental ones, but some of the slightly less quasi-governmental ones can supplement and assist the rest of the sector outside of the sort of EMT deployments. So I think there are ways that they should engage much more, and there are ways that the rest of the humanitarian sector can engage them and bring them into this debate, because at the moment they are innocents abroad. And I think being overly critical of them will simply put up barriers. And actually what we need to do is kind of bring them in and guide them, sit them down, nice cup of tea, this is how it works.
We've heard from Mike, who's in the centre of quite an acute Ebola crisis in North Kivu. And then David talked about some of the more traditional humanitarian responses and the need for adaptation and shifting and changing around that. And what I wanted to talk about a bit more was from the other side of the nexus, from the development programming perspective. So I'm not a humanitarian. I've been working within development programming for a number of decades now, but increasingly more and more realizing that because of the nexus, that shift, that I'm engaging a lot more with humanitarian specialists, looking more about humanitarian strategies and engaging in their programmings. And I thought I could share a little bit of that today from the side of the more traditional development programming. So I'm sure, there we go. I'm sure many of you are a little bit more familiar with Trócaire, but even just we are a development and humanitarian agency, and Trócaire would be the Caritas, and Caritas is the large humanitarian network globally of Catholic agencies within Ireland. Our work focuses on resource use and rights, women's empowerment, and humanitarian preparedness and response. And by resource use and rights, we're working a lot on the stuff you might be familiar around sustainable agriculture, around access to markets, around responding to climate change, and also then access to land and ensuring individuals have access to land and have rights to land and water and the resources that they have. And our work on women's empowerment is all about ensuring that women's voices are heard within their communities and within the politics and political spaces that they're in, and also addressing that, ensuring they live lives free from violence. And aligned to that, we also have all of our humanitarian preparedness and response work in 17 countries across the world. Our humanitarian work has been growing significantly over the last decade. We've gone from working perhaps 20% of our funding on humanitarian to up to 42% currently. And the reason for this is because it's really the massively changing context that we're seeing. The fact that we now have more people displaced globally than ever before. The fact that there is a severe funding crisis and funding shortage to respond to this. Last year when the UN launched 30 humanitarian emergency funds, only 2 of them were up to 50% funded. So we've really seen that there is a massive underfunding of humanitarian globally. And it's a response to the fact that we're seeing within our traditional development programming that much of our work is being undermined by the humanitarian challenges that we're seeing increasingly and by the shocks and stresses. And then also what David alluded to earlier is protracted crises, that it's no longer that idea of a continuum where you have short and quick interventions and then you shift out, that actually what we're seeing within humanitarian is these crises go on for far, far longer, up to 15, 20 years in some of the countries we're working in. So I suppose as a couple, just for the background, a few things for the context of why we're doing joint development humanitarian programming is, I suppose, our theory of change as a start and how we understand that change happens, that as an organisation we work with individuals. We also believe in working with communities, working with civil society and working with government and institutions. And increasingly we're seeing that we need to adapt this theory of change across all of our humanitarian work and across our development programming work. The other part of that is that we don't implement directly, we implement through partners. So with the exception of our work in Somalia, we work through local civil society NGOs and civil society organisations, church organisations, community organisations, NGOs who do the work, and we work in partnership hand in hand with those groups to do the work. So also this has real implications for us in how we work, and again the development humanitarian nexus. We made a really significant decision 5 or 6 years ago when we underwent this new strategic plan to move to what we called more integrated programming. And by integrated programming, we were essentially trying to respond to what we see as a nexus through development, humanitarian, and peace. And because we've shifted towards integrated programming, we've gone through a whole process of, in some ways, nearly turning ourselves upside down and inside out to try and change all of the processes and systems that we have, to change the staffing systems and structures that we have, in some cases to change the partnerships that we have, to relook at all of the strategies and the interventions and how we work in order to be able to work in a more coherent way across humanitarian and development. And this integrated programming is a journey that we're on and has been really, really challenging. And that's what I thought I'd share with you, some of the things that we're learning around that. And also part of that has been responsiveness to Irish Aid, who's one of our main funders here in Ireland. And Irish Aid also made the decision 2 years ago to integrate both their development funding programme and their humanitarian funding together. Again, a response to this nexus and pushing us to plan together and to report together rather than to have two separate reports and two separate thinking and separate strategies around that. And that's really helped us along the journey. But what I thought I'd talk to particularly is, because this is where I think I have most learning to share, and it may not necessarily be focused on health, but certainly I think some of the learnings that we have out from it are still very relevant, is looking at a couple of countries where, like if you look at Zimbabwe, Kenya, Malawi, also Ethiopia last year, what we saw was slow onset, cyclical climate change was impacting very much on our development work. So the work we're doing on resource rights and use, the work we're doing on women's empowerment. It used to be in Malawi that every decade there would be a drought. But what we've seen in the last decade is that pretty much every second year, and now increasingly every year, there is some sort of drought or some sort of floods around climate change. In Zimbabwe, we had the similar experience where we had El Nino, we had drought in 2015 and 2016, followed by floods in 2016, 2017. We've had the drought across all of the countries in East Africa. Again, similar experiences in Kenya, where we're doing development programming work, but more and more we're finding that that program is being upset by significant shocks and stresses related to climate change. And what we found was that our development partners didn't have the capacity to respond to this. Because we had pre-planned development programs in place, we didn't have the flexibility, we didn't have the knowledge, we didn't have the skills to meet the humanitarian need or protect the development gains. Because often what you would have is you would have a development program in place, a shock, a stress would hit, and then communities and families would respond with what we would call negative coping strategies. So for example, they would start to perhaps moving into eating seeds that they had instead of saving seeds for the next harvest. They might start to sell livestock that they had because they had to respond quite quickly in order to get access to money to buy food. And what those negative coping strategies were doing was it was undermining all of the development work that we'd done and basically moving us, shifting us right back to not just where we were before we started, but in an even worse situation than that. And our response to this, again, is, and that's what I thought is a useful thing for us to look at, is the idea of resilience programming, essentially. So what we mean by resilience programming, and this has been a shift for us organizationally, is rather than having a program on women's empowerment or a program on sustainable agriculture and having a goal that this is what you want to achieve, we shifted the goal significantly. And the goal of what we're trying to achieve with the communities that we're working with is that individuals, communities, civil society and institutions are better able to prepare for, to withstand and to recover from these shocks and stresses. And what you're doing with resilience programming is you're shifting the focus, and risk management and risk mitigation becomes a really significant focus of your programming. And you then have multiple entry points, multiple intervention strategies, multiple approaches, and it could be a whole range of different things that you're doing. And your focus is not just on disaster risk is in the humanitarian, your focus is also environmental risk, natural resource management, economic risk, or also socio-political risk around conflict. And that idea there is where you move into the triple nexus, where we're talking about development, humanitarian, and peace together. So your vision is that you're trying to plan and develop programs that respond to both short-term humanitarian needs and longer-term resilience and development needs. You're managing risk as part of the design and delivery of these programs. You're building capacity of some of the traditional partners to plan and implement humanitarian responses. So some of our traditional development partner NGOs are starting to engage in building their capacity around humanitarian responses across a range of different areas. And you're designing and delivering humanitarian responses that can leverage and use the development gains and strategies that you already have in place. And then importantly, you're very actively planning how you're going to transition from development programming into humanitarian programming, back out of humanitarian programming, back into humanitarian programming. And you're doing that in real time so that you're able to respond a lot more proactively. So essentially, you may have a program of nutrition, food security, livelihoods, access to markets, particularly also then looking at some of the implications of malnutrition, of disease when we're moving into crisis and drought and flood. There may be some work around gender-based violence and women's empowerment included in it, but then what we're layering to this and what we're learning from the humanitarian section is around hazard mapping, around better vulnerability analysis, EPP, emergency preparedness and planning, contingency planning, having early warning systems in place so that we're able to track when we see a shift, when we're looking at weather patterns, when we can preempt when there may be drought or when there may be flood, and what we need to do differently in order to respond to that. And then importantly, you're bringing in what are more traditional humanitarian strategies like food for work, food for assets, cash, voucher transfers, and being able to put those. And then of course the psychosocial well-being and the protection. So I suppose some of the big challenges that we see when we try and do this. So when you're a traditional development NGO and you're trying to engage in humanitarian work, one of the most significant barrier and challenge for us is funding. In Malawi last February or March when we were out there, we met with all of our partners. I went to visit some of the local work that we're doing on women's groups around women's participation and voice. And I heard very directly from the women immediately themselves. They're saying, yes, this work is interesting, but my children are hungry. My children are hungry and I'm afraid my children are going to be sick. Now we knew at that stage that we were facing drought in Malawi within 3 or 4 months' time. But there was no funding mechanism for us to put resilience programming in place and to try and respond to that. And that was the really significant challenge. When you went to all of the development funders, they said, yeah, we'll wait until drought hits, come back to us in 3 or 4 months' time. And at that stage, again, we knew that it would be too late and that we would have lost some of the development gains there. So the funding gap is really significant. Again, that played out in Trócaire in northern Kenya in relation to the drought there again. Very similar experiences where we either could access development funding or you could access humanitarian funding. There wasn't anything in between, so there's a particular gap in the middle there around responsiveness. A really important one is shifting management culture, and David spoke to this, and I don't think it can be underestimated. How people think and how they work and how we align ourselves is so huge. And within our own organisations ourselves, that our managers need to be able to bring people together, to be able to plan together, cross-development, cross-humanitarian. It's different languages, different discipline, different strategies, different approaches, and very importantly, very different principles. And that really is quite challenging for us to try and find that middle ground in how we plan together. The inability to adapt. So the fact that through our programming, we plan long-term goals, we set annual targets that we're going to meet, and we're not flexible and adaptive. And because we've signed this off with our donor, or signed it off ourselves in our own minds, that we're not shifting, we're not adapting, we're not changing, we're not working in real time. We're not able to take all of the information and very quickly go, let's do less of that. We need to bring in this strategy, that's not working, shift that up, change that. It takes weeks and weeks and weeks. So just that real challenge of adaptable change management and being a change-ready organisation and a culture like that. The do no harm humanitarian principle considerations, and this one is really significant, and I think where I've seen it play out mostly is particularly in relation to targeting. So these really strong principled approaches, which are really valuable within the humanitarian sector, and how you balance that within the development programming. And so, for example, so we're working with a community where we know drought is going to hit, and we're trying to work with that community to bring in some humanitarian strategies and interventions in order to respond. But that community might necessarily be the community that is most in need. The community next door might be the community that are desperately in need. Yet we're choosing from a development perspective to focus all of our work there in order not to lose the development gains, so that by next year they'll be the community that will be most in need if we don't do that. And there's a real challenge there around addressing need, and the fact that from traditionally humanitarian programming, their priority is need. Within development programming, that's not necessarily the first. We're looking at process, as we described it there. That's not necessarily the first thing that we will be thinking about. We'll be thinking much more longer term. So a real challenge around targeting and principles there. And being political or non-political, and protecting humanitarian space and access. I would very openly say that our work within development programming is political. It's extremely political. It mightn't be political party political, but it's small p. Everything we do is political. Within the humanitarian context, being non-political, whether at least verbally and articulating this, is really, really important in relation to access, and again, in relation to developing, in relation to being able to have access to address need. So that whole challenge around the politics of what you're doing and where you're positioning yourself, and that you may lose your access entirely if you're seen to be too political. If you're doing the governance work that Mike talked to earlier, if you're really engaging with where power is at within governance, that then that may fundamentally challenge you, undermine your whole access and your ability to respond. And I suppose then, because we work through a partnership model, all of these challenges are seen by our partners at that level, and probably much more challenging for them because they don't have the resources that we as big, large development NGOs have to respond to this. So they have all of the same challenges around how do you recruit the right staff? How do you ensure that all of your development staff become skilled in humanitarian, which requires a high level of skills and a high level of awareness that those same people, how do you structure your organization so you have flexibility around funds with your donors, whether your donor is someone like Trócaire who's working with you or some of the larger, bigger donors there? How do you try and negotiate with your donors constantly to have that flexibility and manage their expectations and all of the compliance obligations that are coming with this work? So some of the things that we're learning, and again, this is where the learning, whereas I've talked a little bit about resilience programming within the resource rights and use area, very similar learning I think that's applicable across the health sector, is that what we're seeing is that humanitarian strategies, interventions, working in this way is bringing new thinking to development programming that is really useful. And particularly one of the things I've seen is the protection lens from humanitarian, which is something that we haven't necessarily been that strong at. So really, and as we're seeing conflict increasing globally, as we're seeing closing civil society space and more challenges on our partners, and around what Mike was talking about in DRC when he talked about kidnapping, abductions, violence, conflict, that within the development setting, using protection for us to better understand that there are some basic things that we need to address first before we can even talk about women's empowerment, women's voice, women's participation, that people need to have protection. And I think that's something really useful for us. A much more sophisticated risk analysis, because again, humanitarian sector have been far better at that, and we're learning from that within our development programmings. Emergency preparedness and planning, so just better planning in place around how you shift, how you change. An important area for us as well is who defines resilience, and I think this has been really useful for us, is that certainly coming strongly from emphasizing the process, is that within the development sector we would have been very strong in communities defining their own resilience, and that's really helping us, particularly in relation to some of our humanitarian work around going, well actually we need to, first of all, most importantly, it's working with each of the communities to define, well, what are the shocks and threats that you're facing, what would resilience look like to you, and how will we know whether you're more resilient at the end of the intervention of this project. There's a lot of discussion at the moment around adaptive programming, this whole doing development differently, and I think adaptive programming is an enabler for us when we try and look at the nexus. Adaptive programming is the idea to be, not to look at this linear idea about programming, but being responsive, being flexible, being fast, being able to do some real-time thinking and changing your program, and not necessarily having one long-term goal at the end, but not necessarily having to articulate everything in between around how that's going to change and how you're going to get there. And there's a discussion in some of our donors, some donors are leading this, parts of DFID have been quite good and really moving towards adaptive programming, and I certainly see adaptive programming as an enabler for us as we try and bring our humanitarian and development work closer together. Not in all programs at all times. So it's not, this whole idea of nexus programming is not needed everywhere. In some scenarios it is entirely appropriate and context driven to have a strong humanitarian response and humanitarian alone. In other scenarios you may have that kind of long-term development and you might not need the humanitarian responses. So it's about knowing geographically, funding-wise, when do you need it and where, like in those 4 countries, like Ebola in Sierra Leone, when our development partners had to respond to an Ebola crisis very, very quickly and had to switch how they work. And then 2 years later, when the mudslide hit, again, our development partners were in a better position to respond, because those are the types of situations that you need to respond. And then the other side, the other learning for us, is having a thematic focus. So rather than having these big, broad conceptual conversations around humanitarian and development peace nexus, to be able to say, well, let's look at it in the context of countries where, for example, slow onset, cyclical drought and floods, what does it look like within this context? Let's really focus on what we do there and how we do that joint programming together.